Can somebody let me know if they can see my desktop and see and hear me talk?
I
I can
see
see you.
Okay, thank you very much. I've got a number of things to go over with you. Number one, if you saw the announcement yesterday, I said that I had put up in starter course documents because I'd got a number of people having problems downloading the PhysioX experiments into PDF physio assignments. So I did a video. It's about a minute and a half. It's not very long, where I actually did it. And then I did some written instructions. And I found when I did the written instructions that I had left out a vital step, okay? And so that was my fault. When you got to this dialog box here, you had to click on Microsoft Print to PDF and Print to File. And I had left off that part of the instruction about going Microsoft Print to PDF, because when I went back and followed the instructions, I came up with a PRN file, and obviously I can't open a PRN file. And so that was my fault. I actually had to teach myself how to do this because there is no manual on how to do it. And when I'd put the instructions together, I had not done, not done an adequate job there. And a number of people already know how to do it. You can, these PhysioX can be downloaded in Word files, in PDF, or in text files. Those are the three I can open up. So it really doesn't matter. But now you have the instructions for downloading it in a PDF file. You have a video which you can watch, and you have this. And the second part of that was the fact that if you're aware, number one, I failed to publish the Heart Lab modules in a timely fashion. For whatever reason, I thought I'd already done it. And then when I did publish them, because I copied this course from the summer, it still had the summer dates on it, okay? Because it had the summer dates on it, you weren't able to upload anything. And that was just totally my fault, okay? Totally my fault. And so what I did, if you read the second part of announcement, I haven't changed it on the calendar of activities yet, but I have extended the deadline. Instead of these being due on the 22nd, they're going to be due on the 30th with the blood lab vessel lab modules too. So the heart modules and the blood vessel lab modules are going to be due on the 30th. But I will tell you that because I screwed up, okay, in this first module, which is 17, 18, and 19, if you can get them in before the exam closes, there will be no penalty on any of those first three chapters. And then that brings me to the next item of business. Because I messed up on our lab things, the exam was supposed to open up today and close next Tuesday. Well, I'm going to delay that for 1 week because you haven't, number one, we're just getting a lecture today. And number two, you didn't have time to work on your labs, and that was my fault. So I'm going to delay opening the exam 1 week. And so I will change that. So the exam won't open today. It'll open a week from today. Still cover the three chapters, 17, 18, and 19. The exam will be, I'm just going to talk briefly about the exam. The exam is going to be 125 points. It'll consist of matching, multiple choice, true, false, and short answer. Matching, multiple choice, true, false, and short answer questions. Usually about 2/3 of it is matching, multiple choice, and true, false, and about 1/3 of it short answer. Somebody sent me an email, asked me if there is an exam outline. The exam outline is your student notes, okay? That is your exam outline. 90% of the exam comes from your student notes. 90% of the exam comes from your student notes. May not be verbatim. I won't have the exact question with a fill in the blank, okay? But it will be statements from your student notes. So I would tell you that, number one, if you haven't filled out your student notes, you need to fill out your student notes because that's your exam outline. Because an exam outline would be going through and listing each one of those topics and listing each one of those subtopics underneath it. So that would be your exam outline. with the student notes and with the slides, we're talking about the slides that we go over with the student notes and with the slides, that will encompass 99% of your exam, okay, between 95 and 99% of your exam. So with the student notes and with the slides we go over, that will encompass 95 to 99% of your exam. And that other 1% might be, you know, something that I asked you to incorporate, something that you've learned from your students' notes and student slides, and it would be a short answer question, but it wouldn't be very many points. If I asked you to do something, I probably wouldn't ask you to do something like that. I usually give you hints during the lectures about what's going to be on the exam as far as short answer questions are going to be. In saying that, I'm also having trouble with my editor and YouTube. I don't know why I'm having trouble with that studio editor. I'm going to have to find another editor, but you already have the lectures from last semester. I gave those not very long ago, and they're the same exact lectures over the same exact material. I'm recording these lectures, and when I find another video editor, I'll stick ours up. But you have a lecture from last semester. And like I say, the slides and the student notes constitute 99% of everything that's going to be on the exam. The slides and the lecture and the slides that we go over, okay, Dr. Oler's slides and the student notes constitute 99% of everything that's going to be on the exam. I use the textbook to supplement information. If I don't, like when I get to renal physiology, even though I've studied it several times and lectured on it several times, there's some things that still the light bulb hasn't went off, so I go to the textbook and I reread them before I give the lecture. So your textbook is supplemental. I won't take stuff out of your textbook that's not in the notes or not in the slides, okay? The labs are supplemental because they reinforce the material that you're learning. The labs are supplemental because they reinforce the material that you're learning. So that's about the exam. That's about the lab modules. That's about the videos on how to download or how to convert a PhysioX assignment from the PhysioX into a PDF file. Like I say, you can submit it as a Word, as a PDF, or a text file, any of the three, as long as it includes the pre-lab quiz, the experiment, the post-lab quiz, and the review sheet answers. You can submit it as any of them because I messed up real big time. As long as you get the labs in before the exam closes, there'll be no 10% penalty. But you know, it would be advantageous to you to do them because they reinforce learning points like blood typing. When the blood typing lab reinforce the learning points on that. There's 190 slides. I don't know if we'll get through all of them. We'll go as far as we can on the blood vessels. We're talking about blood vessels today. Remember, the cardiovascular system consists of a fluid medium, the blood, consists of a pump to move that medium around. And now we have to have some conduits, had to have some highways to move that blood throughout the body. Okay, 5 major types of blood vessels, as you can imagine. They're arteries that carry blood away from the heart. As a general rule, arteries carry oxygenated blood away from the heart. Well, we've already learned that the pulmonary trunk and pulmonary arteries carry deoxygenated blood away from the heart because they're carrying it to the lungs, and the pulmonary veins carry oxygenated blood back to the heart. So those are exceptions to the rule, okay? But we have arteries that carry blood away from the heart. We have arterioles, okay? Once we get down, arterioles are usually the last branch before we get to the capillary bed, okay? They're usually the last branch before we get to the capillary bed. Usually the last branch before we get to the capillary bed would be the arterioles. So they are the smaller non-named arteries, okay? All these arteries here would have names, okay? All these arteries here would have names. But when we get down to the very, very, very smallest of arteries, just before we get into the capillary bed, this is the capillary bed, which is where all the exchange goes on. And then we have on the opposite side, we got the capillaries where all the exchange occurs. You know, the nutrients, the gases, everything occurs at the level of the capillary bed. We then have the venules. Okay, we have the venules right here. So these are equivalent to the arterioles. They are on the venous side of the capillary bed. We have an arterial side and a venous side of the capillary bed, and they're on the venous side. And then we have the veins that carry the blood back to the heart. So those are the 5 major types of blood vessels: the arteries, the arterioles, the capillaries, the venules, and the veins, okay? Arteries, there are 3 layers. There is an innermost layer of the artery, okay, an innermost layer that lines the inside of the artery. And as you can imagine, that's the one in contact with the blood. It is lined by simple squamous epithelium, which you know is a one, simple means one cell layer, squamous is a flat cell, okay, and continuous with the endocardial layer of the heart. So it's all big one continuous thing, okay, one continuous smooth layer. We don't want uneven, we don't want narrowing, we don't want flaps, we don't want turbulence, we just want one smooth continuous layer, okay? Then we have a media, okay? So we had an interna, which was our smooth inner layer inside the blood vessel, okay, inside the blood vessel, the smooth inner layer. We have a media, which is the circular arranged smooth muscle, which is going to be utilized when we need to shunt blood to different areas, okay? We may have constriction of that muscle that we're talking about in the very small arteries to shunt blood to another place. And can constrict or dilate, vasoconstriction or vasodilatation. And then we have the external, which is the outside layer, okay? The outside layer consists of collagen fibers to reinforce the blood vessel, may have nerve and lymphatic fibers, and if it's a larger blood vessel, it actually has its own blood supply. So the larger blood vessels have a vasovasorum, okay? Smaller blood vessels just get their blood supply from diffusion from the blood that's actually in the vessel, but a larger blood vessel would have its own blood supply, and that would be in the external, the outermost layer. Types of arteries, we have elastic arteries, which are the big arteries, okay? The ones that recoil when you have a systole, when you have that pulse pressure coming out of the heart, they recoil, they expand and then go back. They expand and then go back, expand and go back. And they are the aorta, the common carotid, subclavian, vertebral, and pulmonary, and common iliacs. Are you going to have a diagram where you have to pick out and name the blood vessels? The answer is no, with the exception of the heart. With the exception of the heart. We spent some extensive time on heart anatomy. So you're going to have to know the heart anatomy, you know, backwards and forwards with regards to you know, the vessels, the valves, the chambers, and where blood goes, okay? But are we going to have a diagram, or are we going to memorize the blood vessels? The answer is no to that, okay? What size are they? 2.5 centimeters to 1 centimeter. Well, in our terms, how big is that? Well, 2.54 centimeters is an inch, so the bigger blood vessels are an inch in diameter to about half an inch of diameter. They're very thick-walled. When you palpate it, you can palpate an artery and a vein, you know definitely the vein is compressible. The artery is compressible some, but it's definitely thicker walled, okay, because of the muscular layer. And like I say, there's a few metric things that I hang on to, and those give me an idea for my conversion. The conversions don't have to be exact, and so that gives me an idea that's probably an inch in diameter. They're the largest arteries. They're nearest the heart. They have the highest pressure in them, okay, fastest blood flow, and smooth blood flow. We don't want any turbulence, okay? Then we have the distributing. So we had the elastic vessels. Now we have the distributing arteries, okay, to distribute blood throughout the blood vessels, throughout the body, okay? And those are the brachial, the femoral, and the splenic arteries, and they are 6 millimeters to 5.5 millimeters in diameter. Remember, a millimeter is a thousandth of a meter. A millimeter is a thousandth of a meter. So they're not very big, okay? Moderate size, distribute blood, pressure and velocity are decreasing, less elastic but more smooth muscle, so they could be more active in vasoconstriction and vasodilatation. If we're sitting, resting, we don't need maximum blood flow into the muscles. But if we're out running, exercising, working in the garden, playing tennis, whatever we do, then we need more blood flow into the muscles, and we don't need as much blood flow into the GI system, okay? So they have the ability to moderate the blood flow. Then we have arterioles, okay, which are from 0.3 millimeters to 10 micrometers. Remember, a micrometer, that's a micron, is 10 to the minus 6 meters, okay? 10 to the minus 6 meters. Just latch on to a few things. Millimeters, 10 to the minus 3. Micrometer is 10 to the minus 6, okay? Micrometer is 10 to the minus 6. Nanometer is 10 to the minus 9. And so you just latch on to a few things, and you don't have to remember everything, you just have to remember a few basic things. Smallest vessels, and then we go to the arterioles or the meta-arterioles. They're the smallest vessels in the circulation. They are microscopic. They're not named, they're microscopic. They are just before you enter the capillary beds, okay? Regulate blood flow into the capillary beds using a pre-capillary sphincter, okay? So in this particular diagram, the precapillary sphincters are relaxed and blood is being perfused into the entire capillary bed. So this may be the GI system. We've had a good meal, we're sitting there, we'll kick back, watching Everybody Loves Raymond at 8 o'clock, or Big Bang Theory, or whatever we're watching, and we're we're perfusing the capillary beds here because the arterioles, the meta-arterioles are open, and blood is going into the capillary beds and of the GI system. Whereas it might not, we've got our feet up on the easy chair, so it might not be going through our as much through our big muscles because we're not using them, okay? As opposed to if we're off, okay, if we're out running, we're not doing so much digesting, okay? We're not doing so much digesting. So the meta-arterioles, okay, the regulating arterioles, meta-arterioles are constricted. And so we got to straight through the meta-arterioles into the venules, and we're bypassing the capillary bed because at this particular time, we don't have to perfuse that capillary bed. And this happens automatically in the body based on what you're doing, okay? It happens automatically in the body based on what you're doing as to what gets perfused. Where is the need, okay? Pressure and velocity of blood flow are still decreasing. Then we go into the capillaries, distribute oxygenated blood to the cells. Remember, the capillaries they have one cell layer thick and a basement membrane. That's it. One cell layer thick and a basement membrane, because you want to have minimal surface to distribute gases, to distribute nutrients, to distribute hormones, whatever you have to distribute out to the cells. There is no direct connection between the blood vessels and the cells. There is the blood vessels which surround the cells. Blood vessels surround the cells. Outside the blood vessels is interstitial fluid, okay? We have intercellular fluid, which is the fluid inside the cell, and we have extracellular fluid. The extracellular fluid consists of two components. It consists of the intravascular fluid, which is fluid inside the blood vessels, and the extravascular fluid, or we call it interstitial fluid, which is the fluid outside the blood vessels, which surrounds the cells, okay? Which surrounds the cells. So that's interstitial fluid. So we're having to move the nutrients out through the capillaries into the interstitial fluid, into the cells, which are all, right next to each other. We're not talking about great distances, okay? Smallest blood vessels, thinnest walls, average length a millimeter, near every cell in the body, but number depends on tissue they serve. Low pressure, slow velocity, exchange materials between blood, interstitial fluid, walls of capillary or basement membrane with a single layer of endothelial cells, a single layer, simple squamous cells. We want to be able to, this happens to me every day about this time. I don't know why that does. Exchange of material between cells and the capillaries. Nutrients, gases, and other small molecules cross the capillary walls by diffusion. Fluid also crosses the vessel walls, forced out by pressure, hydrostatic pressure. Pressure inside the vessel is higher than the pressure inside the interstitial fluid, and it's forced out. Interstitial hydrostatic pressure and colloidal osmotic pressure. So we have a fluid, we have a pressure inside the blood vessel, which is the which is the intervascular hydrostatic pressure, which is pressing, trying to push fluid out. We have a pressure created by the fluid in the interstitial space, which is the space outside the vascular space, which is trying to push fluid back in. And then we have colloidal osmotic pressure, okay, colloidal osmotic pressure, which is the pressure generated by the molecules which are surrounded, which are hydrated and surrounded by water, okay? And we have both those inside the vascular system and outside the vascular system in the interstitial space. But the ones that have the greatest effect are inside the intervascular space. And we'll talk about those more in detail towards the latter part of the lecture. Types of capillaries, continuous they're continuous 4 nanometer clefts, that's 10 to the minus 9th, okay? Fenestrated 20 to 100 nanometer holes. Sinusoids are blood-filled spaces. These are spaces that are not really, these are just almost like collecting chambers. There are some in the liver, there's some inside the head, and these are filled up with venous material. There's some in the placenta. We'll look at, there'll be sinusoids in the placenta. They have incomplete basement membrane, and so blood collects in these spaces. Venules are after the capillaries join, you form venules, thin wall but relatively impermeable. So the impermeability is primarily in the capillaries, okay? Once we get into the venules, then we're back like the arterioles. We don't have very much exchange. The exchange of nutrients and gases and small molecules occur primarily in the capillary beds, okay? Capillary beds are set up for that. Low pressure, slow velocity, very porous, okay? Pressure still falling. This is just an example, okay? Then we have veins, joining of venules, same layers as the arteries. So it have an outer layer, a middle layer, and an inner layer. They are conducting vessels. They are conducting the deoxygenated blood back to the heart, with the exception of the pulmonary veins that conduct the blood back, the oxygenated blood back to the heart, okay? Larger lumens, thinner walls versus arteries. They're very compressible. Blood reservoirs only partially filled. Lowest pressure in the circuit, so veins have the lowest pressure in the circuit. One-way valves. Once we get to the level of the veins, we're far enough away from the heart that there's not really very much of a pressure system, okay? So when we do get blood pumped up into the vein, okay, if we didn't have a one-way valve to keep that in that area, it would just go back down, because most of the time we're standing up or upright, that blood would just go back down due to gravity, okay? So that one-way valve prevents that blood from returning to where it came from. Physiology of venous return. Well, how do we get venous return? Number one, there's a pressure gradient, okay? There's a pressure gradient as we go down the system. And so as we go down the system from the veins to the vena cava, we started getting a little bit of increased pressure. This is primarily how, the two ways it primarily happens is through our muscle pumps, okay? This is why if you're on a long plane ride, they recommend that you, number one, wear support hose, and number two, get up and walk up and down the aisles, okay, to move blood in your veins so you don't get a clot, okay? And also, these are, you can see the valves here, the one-way valves here. So as blood is pumped up through this portion of the vein, as it comes back down this way, this valve closes and keeps it from going back down this direction. So we have skeletal muscle pumps. We have a respiratory pump. When we inhale, we decrease the pressure inside the chest. And as we decrease the pressure inside the chest, blood can flow up through the major, now we're starting to get into major vessels and smaller vessels from the pulmonary system, but blood can flow up because of the decreased pressure. And then we have also smooth muscle contraction in the veins, sympathetic stimulation. We have collateral circulation. We have anastomoses that interconnect blood vessels and capillary beds to ensure multiple sources of blood to different areas, especially to the brain. Okay, the brain's the circle of Willis. If you were in a neuroanatomy class, you'd learn about the circle of Willis and the different branches that supplies blood flow into a circle. So if one of those branches gets knocked out, you still have blood flow going into the circle. But you have multiple anastomoses. So if this particular area gets knocked out, we still got blood flow in this area. We have a portal system, includes 2 capillary beds in series, okay, rather than artery to arterial to capillary to venule. And the one that we'll learn in the GI system is we have blood flow and nutrients into the GI system, okay? We eat and then we digest the food, okay? The food is not directly absorbed into the veins and taken to the heart and distributed to the body. No, the nutrients go to the liver by way of the portal circulation. So we have a 2 circulation for nutrients, and that goes to the liver. Hepatic portal system, veins drain the digestive system, empty into the hepatic portal vein, that in turn transports blood to the liver, allowing liver to pick up choice nutrients. And this is just an example of it. Just know that it exists, okay? You're not going to have to identify the parts of this diagram. You just need to know what a portal system is. Physiology of circulation in regards to blood flow, blood pressure, and resistance, okay? Definition of terms. Blood flow is the volume of blood that flows through a tissue at any given time. Cardiac output is heart rate times stroke volume. We learned about that. Heart rate 72, stroke volume, we learned 70 milliliters, okay? How this becomes distributed is dependent on pressure differences, driving forces, high to low, and resistance in blood vessels. So how the blood's distributed is dependent on the driving force, the pressure differences, and the resistance, okay? The friction in the blood vessels. Blood pressure, force per unit area exerted on the vessel wall by the contained blood. We learned about systolic pressure. It's highest pressure obtained during systole. Systole is ventricular contraction. Atria have an atrial systole, but it doesn't register very much on the pressure. The systolic blood pressure is the ventricular contraction pressure, okay? And diastole is the lowest arterial pressure during diastole. That's when the heart is at rest. That's of the 2 numbers. Obviously, they're both important, but the bottom number is important because that tells you what the pressure is at the heart at rest. Pulses. In arterial, blood enters intermittently through ventricular contraction, and you can detect the pulses. You can get your temporal pulse up on your head. You can get your radial pulse in the wrist, which are the 2 most common to do. A lot of people check their temporal pulse if they're out jogging, or you can do your radial pulse. You can, go into the groin, femoral pulses. You have pulses in the legs. You have pulses in the back of the knee. So there's pulses all over the place. The 2 most common, the most common we use is the radial pulse. A height of pulse systolic pressure can be measured, okay? So the blood pressure cuff is on the arm. We're measuring the pressure in the brachial artery. Normal is 120 millimeters of mercury. At lowest point, diastole can be measured. Normal is 70, 80 millimeters of mercury. So I have high blood pressure, so they like mine to be less than 85 millimeters of mercury, okay? They like the systolic to be less than 140, but the diastolic is the one they're most concerned with because that's the heart at rest. These values are reported as a fraction. Systolic blood pressure represents the force of the left ventricle. Diastolic blood pressure represents the condition of the peripheral vessels. Pulse pressure is the systolic minus the diastolic. Difference is what keeps blood flowing, high to low. Taking pulse involves pushing on the vessel enough to feel the pressure. Pulse rate, 75 per minute. These are the number of places you can detect pulse. You can do carotid pulse. I forgot about the carotid. Do the carotid pulse. Different areas to do the pulses. Mean arterial blood pressure is the average pressure in the arteries. And it's a calculation. You calculate it based on the fact that blood's in the systolic phase longer than it's in the systolic phase. And the mean arterial blood pressure is the systolic blood pressure plus 1/3 of the difference between the systolic minus the diastolic. So that's the mean arterial blood pressure. Or you can do the cardiac output plus resistance, but rarely do you have the resistance for the particular system. Factors that increase blood pressure, increase in stroke volume, we know about that, increase in blood volume, increase in heart rate, increase in resistance, mean arterial blood pressure, cardiac output, finds resistance. If we increase the resistance, obviously we increase the mean arterial pressure. Resistance, due to the friction between the blood vessels and the wall of blood vessels, dependent on blood viscosity. That's why if your hemoglobin gets too high, okay, whether from dehydration, increased resistance, anemia, those things like that, you can get an increase. Total blood volume length, obesity, extra 650 kilometers of blood vessels for every kilogram of fat. And so that's a lot of extra blood vessels. So that's why people who are obese usually have hypertension, because they have to move the blood through all these extra lengths of blood vessels. And that's a lot of blood vessels. This is from Dr. Ohler's slides, since that's a lot of blood vessels for each kilogram of fat, because kilograms 2.2 pounds. And a mile is 1 point something kilometers. So we're talking about for every 2.2 pounds, you know, if we divide that by 2, we're talking about 300 miles of blood vessels. That's a lot of blood vessels. Diameter of the vessel, blood flow is fastest in higher pressure, large diameter arteries. Blood flow is slowest in lower pressure, small diameter arterioles. Resistance varies inversely with the fourth power of the radius. You know, I'm not going to ask you the fourth, you know, a question involving the fourth power of the radius. Just know that resistance varies with the radius. The bigger the radius, okay, the less the resistance, bigger the radius. Because if you double the radius, you get 1/16 the resistance, but you won't have to do a question about it. Wait a minute. Blood picks up speed in the venules and veins as lower pressure is compensated by larger diameter. So the slowest pressure is in the capillary bed. Then the speed picks up, okay, in the venules and the veins, because the diameter gets to be bigger. Okay, so the resistance is lower. This just shows resistance, and this would be an arterial, this would be a capillary bed, and this would be a venule. Okay, maintaining blood pressure. How do we maintain our blood pressure? We got neural control. We got, as you can imagine, you know, it's in the medulla. We have baroreceptors. That's pressure receptors. Baroreceptor, pressure receptors. They sense arterial pressure in the carotid sinus and the aortic arch. Okay, higher than normal stretches baroreceptors, bringing increased signals, increased parasympathetic nervous system, decreased sympathetic input to the heart, decreased heart rate and strength of contraction, decreased activity to the blood vessels, leading to arterial vasodilatation and decreased peripheral resistance, lower cardiac output. Or falling blood pressure does the opposite, decreased parasympathetic, increased sympathetic, increased heart rate, strength of contraction, higher cardiac output, arterial vasoconstriction, increased resistance. We have chemoreceptors that detect low oxygen, low pH, and high CO2, carotid bodies, aortic bodies. Notice all these are in the big blood vessels, cause increased sympathetic outflow and vasoconstriction to speed blood flow, return to the heart and lungs. Hormonal control, angiotensin II, vasoconstrictor, need ACE, angiotensin converting enzyme. This is the blood pressure medicine I take. I take an ACE inhibitor, okay, which blocks this angiotensin converting enzyme. ACE inhibitors lower pressure, okay? So that's what I take, is an ACE inhibitor. It's a very common blood pressure medicine to take. It blocks this angiotensin converting enzyme so I don't get the vasoconstriction. Antidiuretic hormone, diuresis is a output of water. If you have an antidiuretic hormone, you're going to conserve water, retain water, vasoconstriction. Epinephrine and norepinephrine, okay? Epinephrine and norepinephrine, as you can imagine, vasoconstriction, vasoconstriction most of your blood vessels, however, vasodilatation in the heart and skeletal muscles. This is a sympathetic response. Epinephrine and norepinephrine, adrenal sympathetic response for our fight or flight reflex. So we want to have vasodilatation in the heart and skeletal muscle, but vasoconstriction in most other vessels, because we don't need digestion, don't need as much kidney function during that time, okay? Nicotine will also cause vasoconstriction by directly stimulating sympathetic neurons and prompting release of epinephrine and norepinephrine. This is ANF, atrial natriuretic factor. It's secreted by atrial cells when the blood volume and pressure get too high. Antagonizes aldosterone, causes kidneys to excrete sodium and water to lower blood volume, also causes vasodilatation, okay? So this, if the blood pressure is too high, okay, it's going to tell aldosterone, okay, not to retain sodium, because if you retain sodium, you're going to retain water with it, because sodium is a positive ion. Water is a polar molecule. It has a partial positive and partial negative charge, so water surrounds sodium. If you retain sodium, you retain water. So if you antagonize aldosterone and you excrete sodium, you're going to excrete water, and that's going to lower the pressure, okay? Long-term mechanism, alter blood volume, renal regulation. Indirect is renin-angiotensin mechanism. When we get to the kidneys, we're going to talk about this. So this stuff, angiotensin, aldosterone, antidiuretic hormone, we're sort of briefly mentioning, okay? And so this won't be a big factor on this particular exam, okay? Because we're going to cover it in great detail when we get to kidneys. Angiotensin as above, antidiuretic hormone to absorb water, aldosterone to absorb sodium and increase water, thus increasing blood volume, activate thirst mechanism. Kidneys secrete more of less water if necessary without hormone influence by increasing or decreasing the speed of filtration. And that's at a local mechanism. That's a local mechanism based on pressure. Autoregulation, control locally depending on tissue needs. We have metabolic control. Declining O2 levels or increasing waste products cause vasodilatation. Can also be indirect release of nitrous oxide. Nitrous oxide is one of the chemicals that causes vasodilatation, opening and closing of the precapillary sphincters. We have a myogenic reflex. Passive stretching causes increased contraction to slow blood flow, okay? If you have passive stretching, you get increased contraction, you're going to slow blood flow. So that is due to this type of reflex and response. Reduced stretch promotes vasodilatation to increase blood flow. So the pressure, the stretch on the blood vessel, okay, if it's stretching, okay, if it stretches considerably, then it's going to slow the blood flow because it's too much stretch, okay? If it doesn't stretch enough, then it's going to increase the blood flow into the tissue. So this is, and then angiogenesis is growth of new blood vessels, blood flow in specific areas, skeletal muscle, exercise, one of the strenuous situations for cardiovascular system, autoregulatory stimulus, CO2 buildup, O2 decrease. You know, you can get into, with significant exercise, you can get into a CO2 debt, okay? A CO2 debt, and actually go anaerobic. That's when you have lactic acid and start getting the cramps in your muscles, okay? Brain, very little, constant blood flow to the brain. Very little autoregulation. The brain needs blood flow. Very little, but brain sensitive to changing CO2 levels and low pH causes vasodilatation. Lungs, autoregulatory, low pressure, exactly the opposite. If you have low CO2, if you have low O2 in an area of a lung, you get vasoconstriction because there's no sense in perfusing that area of the lung for gas exchange if you don't have any O2 there, okay? So here's an example. If you had a mucus plug or had pneumonia in a small section of the lung, you would not want to send blood flow into the area for perfusion, okay? For gas exchange, not for perfusion. We're going to have blood into the lung to keep the lung alive. But for gas exchange, there's no sense maximizing blood flow into that area because the O2 is low, okay? And if you have an area of the lung that has high O2 levels, then you're going to dilate the vessels there because you want, the whole thing in the lung is to exchange oxygen, is to have oxygen come into the blood vessels. So if you've got an area with low O2, a section of the lung that has low O2, the part that's going to, for respiratory perfusion, is going to be decreased because you're not going to have perfusion because you don't have oxygen there. You have a low level of oxygen. You have high level of oxygen. The blood vessels that are going to be responsible for the respiratory perfusion for a gas exchange are going to dilate so that you get more blood in. Homeostatic imbalances, you can have an aneurysm. This is an aneurysm, okay? You can have different kinds of aneurysms as these rupture. If they rupture inside the head, you can get, you can have a brain bleed if they rupture in the aorta, okay? Rupture in the aorta, you can have significant loss of blood in a very short period of time. Varicose veins, if you get veins overdilated due to incompetent valves, prolonged standing, pregnancy, hereditary. These are normal veins. These are varicose veins. They're incompetent, okay? Your valves don't shut, so you get that backflow and you get that big dilation. Orthostatic hypotension, decrease in blood pressure when one stands up, resulting in dizziness or fainting due to sluggish barrel reflexes, okay? Your pulse should rise when you stand up. Your pulse should rise 10 to 15 beats per minute when you stand up because of the function of the barrel receptors. Atherosclerosis, arteries, if you get hardened in the arteries, less elastic, systolic and diastolic pressure have to rise to overcompensate that. Capillary dynamics, capillary exchange, okay? Simple diffusion. Through fenestrations, okay, through the holes or through the clefts, you can have simple diffusion. You know, diffusion is the movement of a substance from an area of higher concentration to an area of lower concentration down a concentration gradient. So you can have the simple diffusion through fenestrations or through clefts. Through fenestrations or clefts include O2, CO2, glucose, amino acids, and hormones. So gases and small molecules, all plasma solutes, okay? So most of the plasma solutes can go through. Exceptions are proteins, okay? And so the proteins stay inside the blood vessels. So we're talking about what happens at the level of the capillary bed, okay? We're talking about what happens at the level of the capillary bed. Essentially, if there's enough pressure, we'll have all the stuff go out, but fortunately, most of the stuff comes right back in, okay? Brain capillaries are non-fenestrated, and so there's a tight junction, so there's a blood-brain barrier. I'm sorry that that's down there at the bottom there, but it says they're non-fenestrated. There's a lot of, so if you have somebody with an infection in the brain and you're looking up a particular antibiotic, you have to make sure that antibiotic will cross the blood-brain barrier. If it doesn't, then it won't get to the infection inside the brain, okay? Filtration and reabsorption. Bulk fluid moves across the membrane along with nutrients and gases forced out of clefts at the arterial end. And when we get to the kidney, we'll go over this in extensive detail, okay? So bulk fluid moves out at the arterial end in capillary exchange, okay? Forced out because the pressure inside the blood vessels is higher than the pressure in the interstitial space, okay? Return to blood at the venous end of the capillary bed, okay? We're not talking about the venules. We're not talking about veins. We're talking about the capillary bed. So we're talking about a 1 millimeter, 2 millimeter area, okay? Direction amount of fluid that moves is dependent on two types of forces, okay? This is a short answer question, okay? Net filtration pressure is the hydrostatic pressure. These are the pressures that are involved, okay? Net filtration pressure, hydrostatic pressure is dominant at the arterial end, okay? That's pushing fluid out. Net absorption pressure is the colloidal osmotic pressure, which is the pressure generated by the material that is still left in the intervascular space, okay? Intervascular space, because it is too big to be pushed out by the filtration pressure. Hydrostatic pressure, a force that is against vessel walls due to fluid pressure. Hydrostatic pressure is higher at the arterial end than the venous end as pressure drops through the capillary, okay? Hydrostatic pressure is higher at the arterial end than the venous end as the pressure drops through the capillaries. Hydrostatic pressure, so this is hydrostatic pressure in the capillary on the arterial end of the venous end. This is hydrostatic pressure in the interstitial fluid, okay? The interstitial fluid has a hydrostatic pressure. It opposes the movement of the fluid out. So if your capillary pressure and your interstitial hydrostatic pressure were the same, there'd be no net fluid. There would be no net fluid movement out. But the capillary hydrostatic, the interstitial fluid hydrostatic pressure is much lower than the hydrostatic pressure in the capillary, so fluid is forced out. Hydrostatic pressure in the capillary is about 35 millimeters, okay, of mercury at the arterial end. So this is the capillary bed. This is the arterial end. This is the venous end. The pressure inside the vessel is 35 millimeters of mercury at the arterial end. The hydrostatic pressure at the venous end is 17 millimeters of mercury. The hydrostatic pressure of the interstitial fluid is 0 at both ends. So essentially it's insignificant. So we got hydrostatic pressure of the capillary of the interstitial fluid, 0 pushing back against the 35, 0 pushing back against the 35. Net filtration pressure, arterial hydrostatic pressure 35 out, minus 0 equals 35 out. Venous hydrostatic pressure 17 out, minus 0 equals 17 out. So far, all the fluid's going out at both ends, okay? So if this was the case, then all the fluid would go out of at the capillary bed by the time the blood went through the capillary bed, okay? Concentration, so now we're talking about the colloidal osmotic pressure, concentration of large, non-diffusible molecules, generally proteins, okay? So here they are inside the vessel. These molecules draw fluid towards them. The osmotic pressure inside the capillary is 26 at both ends. So 26, 26. Osmotic pressure is 26 at both ends. Osmotic pressure of the interstitial fluid is 1 out at both ends. So there are molecules here, okay? There are molecules here inside the interstitial fluid that has a tendency to push. So they didn't, it would have been better if they'd made some molecules out here, because molecules out here is causing this by a factor of 1 millimeter of mercury to come out. So 26 in, 1 out on the arterial end. It says at both ends, okay? So 26 in, 1 out at the other end, okay? Net absorptive pressure at the arterial end, okay? At the arterial end, we had a net of 35 pushing out. We had 26 pushing in colloidal osmotic pressure inside the vessel versus 1 out colloidal osmotic pressure outside the vessel for a net of 25. So net arterial pressure at the arterial end, net osmotic pressure at the arterial end is 10 out. But what is it at the venous end, okay? We have 17 going out. 17 going out. We have 26 coming in, 1 going out, minus 25. Net arterial pressure here is 8 in. So 10 out at the arterial end, 8 in at the venous end. So 10 out, 8 in. So our net filtration pressure is going to be 2 out. So our net filtration pressure, how much fluid goes out and stays out, is due to 2 millimeters of mercury pressure. That's our net filtration pressure throughout our capillary bed. So what happens to that? The lymphatics pick it up. The lymphatics pick it up. And our next chapter, which is chapter 20, we'll talk about the lymphatics picking this fluid up, which turns out to be a fairly significant amount of fluid. Okay, so this is a schematic. So I'm telling you in advance, okay, I'm telling you in advance, this is going to be a short answer question. It'll probably be 10, 15 points for short answer question because it's fairly extensive. And what I'm going to do is change one of these things, okay? I'm going to change one of these things. And it's the colloidal osmotic pressure, okay? If I change the colloidal osmotic pressure inside the blood vessel, what happens to your net filtration pressure? So you need to be able to work through this problem, okay? I'm telling you in advance that when the test opens next week, remember, I'm delaying the opening of the test 1 week. This is going to be one of your bigger short answer questions, okay? I'm going to give you all these same parameters, except I'm going to change the colloidal osmotic pressure inside the blood vessel, okay? and you're going to need to work through that problem. And it's not hard because you've got the thing in front of you. All you have to do is change the colloidal osmotic pressure and work through the numbers and find out what the total pressure is. So I'm telling you in advance, this is one of your short answer questions, okay? It's going to be, like I say, I think about 10 points, maybe 15 points. So it's a fairly significant question that you need to be, so you need to understand this. So what you need to do is after the lecture, go back and work through this problem. And it's not a hard problem because it's just pressure out and pressure in, pressure out and pressure in. And what are the factors? The only thing that's going to change is the colloidal osmotic pressure. And I'm not going to work the problem for you. I'm not going to tell you what the problem is, but I actually told you what the problem is. I'm just not going to tell you what I changed the colloidal osmotic pressure to. And here's a schematic of what we just talked about. End result, 85% of filter fluid will be reabsorbed. Lymphatic system picks up the rest. Homeostatic imbalance, you get an edema, excess fluid, okay? You can also see this if you get a groin dissection. Say you had a groin dissection where you take the lymph nodes and interrupt the lymphatics. You can get something like this. We used to see it a lot when we in breast surgery, when you did modified radical mastectomy and axillary dissection, remove the axillary nodes. Well, when you remove the axillary nodes, when we learned about lymphatics, you'll find out that's where the lymphatics drain into is into the nodes, so that the nodes can be a surveillance mechanism for picking up cancer cells or microbes or stuff like that. You can get fluid accumulation, okay? Increased capillary function, increased blood pressure, poor venous return. And so you get an imbalance there where more fluid out. Reduced capillary reabsorption due to blood albumin, liver disease, kidney disease. Well, blood albumin is one of the major things for colloidal osmotic pressure, responsible for most of the colloidal osmotic pressure inside the vessel. So if you reduce that by half, what would that do? Hint, hint. Okay. Obstructive lymphatic drainage interferes with interstitial fluid drainage. And that's the end of the slides. So in summary, we talked about at the start of the lecture, we talked about a number of things. People are having problems with converting PhysioX into a PDF file. I have put both written instructions and a video. Tells you, the video is a minute and a half, okay, and the written instructions tells you what to do. Unfortunately, I left off one step when I did the written instructions, which is what you have, and the step I left off was when you got to this dialog box here, you had to click on Microsoft Print to PDF and click on Print to File. I said Print to File, but I didn't click that part, and some people picked up on it and some people didn't. You can download these as Word, as PDF, or as text files, okay? So and the second problem I ran into was when number one, I failed to publish them in a timely fashion when we did the unit, so they weren't available to you. When I did publish them, I forgot that I had copied them from the last semester, so it still had last semester dates. They weren't accessible. Somebody emailed me. If you see a problem like that, please email me right away, because that means I made a mistake. And I'll even thank you for emailing me. Okay? Because I don't know about it, if somebody doesn't point it out to me. So I went ahead and changed the dates on that. And what I did was, I haven't done this on the calendar of activities, but the due date, which should have been for September 23rd, is now September the 30th, okay? So the due date for the heart module, lab module, September 30th. And so that works out better for you. Since I messed up on the labs, we were scheduled for the exam to open today, and you have a week to complete it. But since I messed up on the labs, and we're just talking about this, the last chapter that's supposed to be on the exam, I am delaying the exam. The exam is going to be delayed. It's going to open next Wednesday, which will be the 23rd, okay? It'll open next Wednesday, which will be the 23rd, instead of opening today, okay? So you have time to get through the labs and get that stuff and get your stuff done. I'm going to be lenient on the labs. So if you get the labs to me by the time the exam closes, which will be sometime in October, then there won't be any deduction on them. But you obviously should try to do the labs before you have the exam. I said a little bit about the exam. The exam is multiple choice, true, false, matching, and short answer. I just illustrated to you one of your short answer questions. I illustrated to you a short answer question and actually told you the question. If you were listening real hard, I told you what I was going to do and what I was going to do it to. And so there'll be short answer questions. There are other short answer questions that I've given you hints about. There is no outline for the exam. The outline for the exam is the student notes. Okay, each week we've had student notes on chapter 17, 18, and 19, which is their fill in the blank notes. That encompasses 90% of your exam. The notes and the slides encompass 99% of your exam. So the notes and the slides are 99% of your exam. Those are what you study for the exam. The notes and slides are what you study for the exam. I'm not going to do a proctored first exam, so obviously it's open slides, open notes. You'll have a week to do it. It's a 2-hour exam unless you have extended time. You only have one opportunity to do it. So once you press begin, it's yours. Okay, at the end of 2 hours, it'll submit. So make sure you get ready. And we'll go over that before I open it up, and you'll have an announcement about that. But I'm delaying the exam for a week. I'm delaying the due dates on the lab modules because I messed up on the lab module number 2 for our second lab module, which had been chapter 18. And I told you about the written instructions and the video if you're having a problem with the PhysioX. The video is really good. I made it using the blood. I did the blood thing, and then using that, I made that video. And like I said, it's only a minute and a half. And I forgot that one instruction because I had to teach myself how to do it. There is no instructions for doing this. I had to teach myself how to do it, and then I forgot to put that one instruction there. So we're done. Does anybody have any questions for me? So there is no exam. Exam's not going to open this week. Okay, it's going to open next week. So you have another week before the exam opens. Work on your labs. Go through your notes. You know, I would tell you to know your notes code. I mean, you're going to have open notes. The problem is if you don't know where stuff is in your notes, okay, then you're going to have to flip through, 10 pages of notes to find the answer or find what, where you at least can read and try to figure out what the answer is. So you need to have gone through your notes and know where things are. Trust me, I know that for a fact, okay, from my classes, because if I didn't read the chapter and then tried to take the exam, I'd have to flip through the whole chapter, okay? So I know that from a personal fact. And go through your notes and then look through the slides. Again, you have everything that you need for the exam. Textbook is supplement. I use the textbook when I don't understand something. I use the textbook when I don't understand something. I go and read in more detail. If still after the textbook I don't understand it, then I go to YouTube. I type in whatever the concept it is, and I get 10, 15 videos explaining it to me what I'm trying to do. So that works out real good too. Any questions for me? All right, then we're done for today. I will see you next week. Let's see if there's any questions on chat. All right. Okay. Study groups are good. They're really good. As long as you study, they're really good things to do. Okay. All right. So if you need me, email me. I'm good about responding. Like I say, if you find mistakes, just email me. I'm happy that you found a mistake and you told me, okay, because then I can correct it. Like on the first one is I hadn't even opened up the modules, and then when I opened them up, I still had the wrong dates on them. So when you do that, I'm happy about it. I mean, I'm not happy because I had to do something, but I'm happy that it got found out, okay, and I can take care of that. Well, I guess I didn't need to go there. All right.